My name is Anani. I will be giving this talk. Hopefully everyone will get a little something out of it. My goal is at least if everyone can take home either one new point or 1 point to remember I did something right. I do have a little pointer from time to time. They don't always show up on computer screens, so I'll just kind of gesture my best Vanna White arms. All right, so moving forward, some objectives. I stand close to this, I believe. There we go. I want to review what a stroke is, some data on the stroke. I did not create the data, it's from the CDC. I'm not that smart. Then we're going to discuss 3 worry types of strokes. I didn't want to just cover the most common. I wanted it to cover when people walk through the door and they tell me, I think I'm having a stroke or blank, blank, blank stroke. The 3 types I hear the most and kind of help everyone figure out what those are. How everyone can help. I like to say from a 5-year-old to a 100-year-old, you can help us improve stroke outcomes. Then we're going to review what everyone should expect when you go to any emergency department on the planet, I feel, and then what you should expect when you come to NorthCrest, how NorthCrest can help, and how I feel NorthCrest can be a great resource. All right? So next, though, someone once told me no one wants to hear you talk unless they know a little bit about you. So some of the things which have already been pointed out, I work for American Physician Partners. It's basically an emergency medicine group. I'm a medical director for them, and they have me staffed at NorthCrest. But I've been NorthCrest for the past 3 years, even before APP got there. I am the Robertson County EMS director, so I basically double check all of their medical things. So, you know, if you say my chest hurts, I pre-approve all the medications you should be getting in the ambulance. But I do not hire or fire any paramedics, so if someone did anything wrong, I have to give you a different email address for that. I am board certified in emergency medicine. That just means I pass a lot of tests. In my free time, I do enjoy video games. I'm a nerd. I never really gave up that habit. The PS4 is my game of choice or game platform. And I married my medical school sweetheart. Her name is Uchenna. She works at Vanderbilt, and that's how we ended up in the Nashville catch. She works in the NICU, so little small babies, which I am terrified to take care of. So I leave them all to her. All right, so stroke stats. There are about 140,000 strokes that kill, unfortunately, an American citizen every year. The most famous recently, which actually made me hurt, was Luke Perry, famously of 90210. He had a large stroke, and he passed away, unfortunately. There's a stroke about every 40 seconds, and then you extrapolate that every 4 minutes, someone dies. Don't think about it every time your clock ticks 4 minutes, someone passes away. It's just somebody with a lot of math and a lot of time came up with that stat. There are about 795,000 people who have a stroke in total, whether small or big. And actually, the majority of those strokes are people who've had strokes before. I think it's about 300,000 plus have already had a prior stroke and then had another one. About 87% of them are ischemic strokes. You don't have to really know what that is. I will get into that. But that's just, remember that word ischemic stroke? 87% is the vast majority. And I'll tell you again how you can all help us prevent those. And stroke is the leading cause of serious long-term disability. So if you think about it, you'll hear me say it multiple times. Once a part of the brain dies, it cannot come back. So if someone can't move their arm and they don't get the proper treatment fast enough, their arm will not be able to move again. With the appropriate treatment, your brain can kind of come up with new pathways and new nerves to get your arm to move a little bit, but you're never going to have 100% function again. So that can leave long-term disabilities. If someone wasn't talking right, and then they don't go to the emergency department soon enough, they will be misspeaking for, unfortunately, the rest of their lives. All right, here's a map of everyone that's had a stroke in the country between 2014 and 2016. There's a couple factors I want to point out. The first thing is check the age. It's 35 plus, all right? It's not 65, it's not 75, it's not 80, 35 plus. That's when you should start thinking about potentials of strokes. I even say 30 personally. Then, without crunching numbers too high, dark purple equals lots of people. Hopefully everyone here passed, we are in a school building, I hear, passed basic geography. You can kind of see Tennessee, you can kind of figure out where we are, dark purple area. We can do a little bit better there. My wife also pointed out to me that the coast, like California, has a lot of people as well, unlike the LA area, but they're not as dark as we are, even with less people. And that's, again, a balance act, you know, 1 in 1,000, things like that. Californians do eat a lot more salads and avocados than we do. And even in the New York area where there's millions upon millions of people, it's not as dark. Some people think it's the activity. You walk a lot more if you live in New York. There's subways, buses, not as many cars, things like that. All right, so some definitions. From Merriam-Webster, which I think is probably the best dictionary, a stroke is defined as a sudden diminution of or loss of consciousness, sensation, and voluntary motion caused by rupture or obstruction of a blood vessel of the brain. That's a lot of words. So I am going to present to you the simple medical definition. Any process that disrupts the flow of oxygen and substrate-rich products to the brain is called a stroke. Anything that can cause that, whether it's too little blood, not enough oxygen, anything that can affect oxygen to the brain, call it a stroke. So, the first kind of stroke I want to talk about is the ischemic kind. That was the one we talked about in the previous slide that 87% of people in the US have. I like to give nicknames to things. You will not find this in any medical journal that I looked up, but I like to keep things simple. So when you think of an ischemic stroke, think of the no blood kind. For some reason, there's lack of blood getting to the brain. And because of that, that's why you're having that stroke. Because lack of blood, it carries the oxygen, you get to your stroke. The most common type is a thrombotic. Again, my nickname, the plaque builds up. This is the most common age-related, I like to say. You have a lot of cholesterol, your platelets build up, all of a sudden, they start stacking on top of each other, they block a whole vessel, boom, stroke. The second most common is an embolic stroke. Think of it as a traveling clot. You have people say, oh, there's a blood clot in my leg, there's a blood clot in my arm. We're always scared of those, not because they affect where they are, it's because they move eventually. So if it makes it to the heart, you can get a lung clot, but if it goes to the brain, you can get a stroke. The most common kind of patients that have this embolic or traveling clot is the patients with AFib. You've probably heard of that. It stands for atrial fibrillation. It's a funny heartbeat, basically. Your heart's not beating at a normal pace. So every now and then it squiggles, and because of that extra beat, it throws a small clot, and then it goes to your brain, you get a stroke. You may have heard of small children getting holes in their hearts replaced or holes closed. It's because if those holes stay open, it's easier for clots to get to the brain. So that's why people with AFib are chronically on a blood thinner. It does not treat the AFib, it's to prevent clots. And the last kind is hypoperfusion, or the low blood pressure kind. Basically, there's not enough blood getting to the brain, you will have a stroke. The most common kind I can use as a simple example, when someone has a heart attack, the heart isn't beating well. So we do CPR, of course, to try to get it. And if you've taken the class, you know, everyone says get your depth in 1.3. You want enough pressure to get blood to the brain. So if we do restart the heart, there's no deficits. But sometimes you'll hear people, their heart's coming back, and what do you hear? They're brain dead. Just think of that as a massive stroke. They can't regain any function. The next kind of stroke I like to talk about is a, part of the brain dies, I said that already, is a hemorrhagic stroke, or the too much blood kind. So this is the kind of stroke where blood is actually inside the brain where it shouldn't be. So it's not in blood vessels, it's outside of it. The most common is a intracerebral hemorrhage. So basically, if you think of a little brain, picture a brain, pick any part of that brain, take that tissue out, put blood in, that is an intracerebral. It's in the cerebrum. And that type of blood, because of the pressure it causes, can stop blood flow to that area. And if blood is growing in the brain, it's not going somewhere else. So that is known as an intracerebral. The next is a subarachnoid. Just think of it as space around the brain. So it kind of coats around the brain. And that type of stroke, or both of these actually, I like to call the high blood pressure type. So a lot of times as an emergency room physician, patients will come in and they say, my blood pressure is high, I'm scared I'm having a stroke. They walked in, they're moving everything, they're talking normally, but they're afraid. And everyone's afraid because if your blood pressure gets too high, has anyone heard of an aneurysm before? It's a fancy word for ballooning. If your pressure gets high enough, it can pop that balloon, and then you have one of these types of strokes. So usually high blood pressure doesn't cause the ischemic strokes as much, but it's dangerous for the hemorrhagic strokes. The one thing I like to tell everyone is everyone has different pressures, right? I can pass out 10 balloons right now, and some balloons will pop on the first blow, and some balloons will expand to the size of this room before they pop. Same thing with aneurysms. Some of them may rupture, unfortunately, at 190 is the top number. Other ones can take 250 at the top number. I've seen someone literally walk in and ask for a Coke, and their blood pressure was 220 over 100. I'm like, what's going on? They're like, just need a Coke. I think my arm's tingly, by the way. It's like, okay, fine, thank you. We found something out here. Those kinds are easy and simple to treat, and we'll get to that a little bit later. Yeah, exactly. The third kind is what we've all heard of, the heat stroke, or I like to call the hot kind. So the thing about heat strokes is they're not actually strokes, or they're not a true stroke, as I like to say. They're caused by severe high temperatures, usually about 104 degrees Fahrenheit. Not the temperature outside, the temperature in your body. In emergency medicine, we have a scale. There's everything from heat exhaustion all the way up to heat stroke. To qualify as heat stroke, you should have, this is going to blow your minds, stroke-like symptoms. So you get so hot, all of a sudden, you're not able to speak normally. For some reason, you can't move your arm. What they found is the temperature has just led to organ dysfunction, and the brain is one of those organs. Your body can't thermoregulate properly, and it's just going all out of whack. This kind of stroke is not overly time sensitive because you don't have to get there fast, but you don't want to stay hot for too long. So just because you feel hot and you're out of it, don't say, oh, this is a heat stroke. We have 5 hours to get to the ER. But it's not time sensitive, as we can reverse it no matter how long you get in. All right, so how everyone can help. You don't have to go to medical school. You don't have to carry around different medications in your pocket. There's one simple thing: early recognition. And then early recognition, and then more early recognition. Can anyone guess what's next? Thank you. And then there's some more early recognition, and then, of course, I can't stress this enough, early recognition. All right, early recognition, early recognition. And you're probably wondering why I'm beating on this point so hard. Strokes, especially the ischemic and the hemorrhagic kinds, are time sensitive. It means the best treatment we have found through all the decades of medicine can only be given usually within 3 to 4 hours. Every now and then, you get your cowboy neurologist. They'll try something at 4.5 hours. Maybe if you're really young and they want to get you back on the field, they'll try at 5 hours. Outside of that, it's done. We can do nothing else. And I mean we in the colloquial medical sense. So the first thing you can do is recognize the signs and symptoms and get to a hospital quickly. So, people, again, much smarter than I, the American Heart Association and the American Stroke Association said, hey, we need to get this message out. How can we do it fast? Well, let's just use the word fast and help everyone remember the signs and symptoms and figure out what to do next. So the F in FAST stands for face. This is what most people can notice, even your 5-year-old. Grandma, your face is droopy, or for some reason you realize you can't lift it or you're not smiling properly. That's your face being asymmetric or not even. The A stands for arm. And even though it's arm, it can be leg, but FLAST doesn't work as well, so we're going to stick with that. If your arm is weak, you can't lift it, numbness and tingling counts, that's a sign and symptom. Speech is probably the first symptom you recognize in yourself. We don't walk around looking at mirrors. Like right now, one of my giant fears is, do I have a booger in my nose? But there's no giant mirror. I do. See, I knew it. I'm stuck like this though. But you can't see your own face, and your own arm. If you're watching TV, you're not trying to lift too much, so you may not notice it. But we all talk to ourselves sometimes. And out loud, if you hear it, and you don't sound right, that's a good symptom. And the T is time. Time to call 911. Not time to think about it. The thing I hear a lot in the emergency department is, I was giving it some time. That's not what it stands for. Time to call 911. Because the more time you take, the more time you're wasting. A lot of people say, oh, I was just going to give it an hour. Or I was going to wait till the end of this episode of CSI and then I was going to come in. No, come in right away. There's DVR. The thing about this is it's a little short. So in the honest interest of March Madness, I went to the Duke Medicine website. I don't like Duke, but I'm just saying, at least Tennessee's still in it, right? We have some kind of hope. There has been some programs that have added on a few letters. It's the Be Fast campaign. As far as I can tell, the AHA hasn't taken this on completely, but it's nothing too out of the norm. The B stands for balance. So some people will realize they're not walking straight, or for some reason they just feel like the whole room is spinning. Yes, that could be vertigo, but it could be a cerebellar stroke. Let us figure it out in the emergency department. The other one is eyes. Have you lost vision? Sometimes, if you remember what we've been talking about a lot, strokes are lack of oxygen, lack of blood flow. So your eyes are technically part of your brain. So if there's a clot that goes to that area or a clot that goes to your brain that controls vision, that's the stroke symptom you're going to have. You're not going to have arm weakness or speech. It's going to be just your vision. Then, of course, we've gone over the FAS already. And then again, the T is call 911. All right. So what you should expect when you go to any emergency department, I believe, on the planet, or that at least has some machines in it. Prompt and expedited recognition. When you get to the emergency department, there's not a doctor at the front usually. There's either a tech or some sort of staff. You sign your name, they ask you what you're here for. I always recommend use these words. I think I'm having a stroke. Because if you leave anything up to chance, you're leaving that person who doesn't have true medical training to interpret it. And if you're not at a stroke center, they're not thinking stroke because they didn't get that training. So if you walk in and say, my arm's numb, they're going to think, oh, it's just arm numbness. They're not thinking stroke. Or if you walk in and think, my vision's a little blurry, not everyone's thinking stroke. So if you walk in and say those words exactly, you should, unless the emergency department is completely full, be brought back and examined very, very quickly. And again, let a medical provider figure that out. You should get a complete physical examination. That's not always making you do jumping jacks or pull-ups or something, but somebody should have you at least squeeze their fingers and can you move your arms and legs. That's the bare minimum. Everything else we can see just looking at you. Again, looking, you can see if the face is symmetric. When someone says, how are you doing? If you respond back, that means their speech is normal. We can do those quick evaluations. But again, squeeze my fingers, lift your arms and legs, and can you feel this? Quick standards. In a CAT scan of the brain, again, if an emergency department has one, you should get one immediately. I like to use this point to say that CAT scans do not show ischemic strokes all the time. CAT scans will only show large ischemic strokes. CAT scans will show hemorrhagic strokes. So blood in the brain, we need to know ASAP, ASAP, ASAP. So that's why you get a CAT scan so quickly. But if someone tells you your CAT scan's negative and they're still concerned about stroke symptoms, you need an MRI. You will not always get an MRI in every emergency department. Heck, I know some that don't have an MRI, but the MRI is really useful for just location diagnosis and size diagnosis. The diagnosis of saying this person's having a stroke should be mostly medical. It should be your signs and symptoms. We're using that test to kind of bolster our thoughts or confirm it, but that's all it's really there for. And again, labs. Now I'll explain why your blood should be drawn anywhere as we move forward. So, ED expectations. So you guys at least now know the 3 types of stroke: the not enough blood kind, the too much blood kind, and the hot kind. You should expect certain things treatment-wise, and I wanted to kind of outline those, because sometimes people come to me and they say, I think I'm having a stroke, and all I do is kind of say, we're going to get an MRI in the morning. And they're wondering, you're not going to do anything else? Well, it depends on when you came in. So for the ischemic stroke, if the patient arrives within 3 to 4 hours, we can give a clot buster, known as TPA. So 87% of strokes were the ischemic kind. The vast majority of that were the clots that built up, and the other ones were the clots that traveled. So in medicine, we thought, hey, if we give a clot buster, we can restore blood flow and get the brain moving again. But they found you really have to do it in about 3 to 4 hours, because the brain doesn't really recover after that. Also, that clot buster busts up clots everywhere. So if you have a clot, let's say you bruised your lung and there's a clot there, it may break up that clot too. So we don't like to give it just because we're concerned you can cause bleeding in other places. If you're out of that 3-hour windows and you can't get the clot buster, we do now have fancy machines that can go through your arteries and veins and literally grab out the clot. But those, again, 3 to 4 hours. 4.5 hours if you have a really cavalier neurologist. But even then, they all prefer TPA to be given before, because it's like, I hate to use the example, getting a clot out of your drain. Yeah, sometimes you need a snake to get it, but you still put Drano in it first. So that's what we're trying to do with the body. If we can't do any of those things, we will admit you to the hospital, get an MRI, determine your location, and then move on from there to kind of help you live your best life if we think there's going to be a disability afterwards. Also, a lot of people come in and are very concerned about mini strokes. Mini strokes are known as TIAs, and as far as I'm concerned in medicine, telling everyone out there in the community, mini stroke symptoms are gone in an hour. That's the medical definition. If you still have any symptoms 2 hours later, 3 hours later, you're not having a mini stroke. It is a stroke. MRIs can help us figure that out as well if you get them within the first hour of your symptoms. But if you woke up at 3 o'clock with bad speech, or if you were awake at 3 o'clock with bad speech, and at 4 o'clock you're still speaking bad, at 4:01 you have a full-blown stroke. It's no longer mini. For the hemorrhagic kind, the first thing we do in the emergency department is reverse the bleeding. Is it caused by your blood pressure? Are you on a blood thinner? How can we stop the bleeding? We will give you any type of blood product we possibly can. And then the second actually depends on how much blood there is. Sometimes, as physicians, we go up there and get the blood out. So we'll send people for craniotomies, drain the blood, stop it, or if there's an aneurysm, coil it. But if it's a small bleed, you'll be surprised. We leave it alone. We watch it, get CAT scans every couple hours, make sure it doesn't grow. Surgeries do save lives, but they also take lives sometimes. So we have to weigh the risks and the benefits of doing any procedure. And then the hot kind, you will be surprised, we cool you off. But you need to be cooled at an appropriate rate. You don't want to drop the temperature very quickly. And the one thing you do not want to do is throw them in a bathtub or anything full of ice. The main reason with that is you will cool them, congratulations, but they will shiver. And actually the body shivering can produce more heat. So sometimes your temperature actually goes up. Sometimes if you drop too quickly, you can cause seizures and other things like that. So again, come into the emergency department. We have fans, nice water things, nice water treatments. We will cool appropriately and monitor for any organs that may have been damaged. So, how can NorthCrest help with all of this? I ripped this from the NorthCrest website because I could not draw this well. This is where NorthCrest is all located. You will see where it's located nicely in the Springfield area. There's a little arrow over there by exit 108 pointing to where we are in White House. It is actually very close mileage-wise. Looking at the map, I was like, oh, that's at least an hour away. Got here in 22 minutes. Not that long. Definitely not 3 to 4 hours when you need stroke treatment. It is a primary stroke center, which I'll talk about a little bit here. And one of the great resources of a primary stroke center is you can use the word primary. We have everything you need in the first step of treatment to treat a stroke. The only thing we don't have, which I won't lie about because we don't have it, are those fancy machines to go up and get the clot like I talked about. But you need a neurosurgeon for that, and we don't have a neurosurgeon. That's okay. We can handle that 87% of strokes. We can handle that. So what we do, and what anyone who's a primary stroke center, you have to be held to a higher standard of care. I mentioned earlier that some emergency departments don't even have CAT scanners, so how could you be a primary stroke center? In order for us to get it, we had to have a CAT scanner, train all of our physicians in NIH stroke scales. Oh, that went really quick. That was not my fault. NIH stroke scales, and make sure everyone's on the same page. You also, by government standards, have to be able to give TPA the clot buster within 1 hour of arrival. So if you come to the NorthCrest stack desk and say, I think I'm having a stroke, you will have a complete workup, which we'll get to on one of these slides that I previewed. You will have a full stroke workup in under an hour, and if we deem that you have a stroke, you will get that clot buster within an hour of arrival. So again, time sensitive. If we need an hour to work it up, and you took 3 hours to get in, we only have, that half an hour if you have the Cavalier neurologist left to kind of give it. The other thing is we have a direct connection with a comprehensive stroke center. Our comprehensive stroke center that we have affiliation with is Vanderbilt. They have the fancy robot down there. In order to keep the connection going when you come into NorthCrest, if I was working that night, I do the full assessment, get everything ready. We can actually speak directly to a neurologist 24/7, 365, discuss the patient, and actually show you to the neurologist. We don't use anything like spaceship technology, just an iPad with FaceTime, but you will be surprised how well it works. Everyone's used FaceTime now in 2019, just about. Everyone knows what an iPad looks, and they only need to look at you. I'm still right there in the room. It's not a fancy robot rolling in and rolling out. I'm there as a doctor. That's just my consultant. So you can't see this, and my wife reminded me that nobody can see this, but I want everyone to take a full grasp at what we have to think and do when you come to NorthCrest and say the words, I think I'm having a stroke. This is our acute stroke decision tree. You don't have to memorize it, you don't have to think about it, but know that we do not take it lightly. Strokes are serious, and we treat them seriously. So when you come in, this is the top of that box, we do that whole be fast right when you get to the door. We need to know if you had numbness, difficulty speaking, assess your vision, assess your balance, determine if you have any bad headaches, and when all of these symptoms happened. Did you wake up with it? Did you go to sleep with it? Has it been going on for the last 2 or 3 hours? Is it 2 or 3 days ago? We have to get all of these questions out rapid fire. Then we have to still assess your airway, your breathing, and your circulation, the ABCs, to make sure there's nothing else dangerous going on. Then comes the fun part. We have to do all of this within 10 to 15 minutes of arrival. Now, if you can't see all of this, we have to get the stroke team to respond, draw all of those labs, which take up 2 bullet points, get a CAT scan of your head, get 2 IVs in, an EKG, connect you to a monitor, get a chest x-ray, make sure you don't eat anything, calculate your NIH stroke scale, and start to dial the neurologist after I get my CT results back. All of that should be done in about 15 and 30 minutes once you come to NorthCrest and say the words, "I think I'm having a stroke." Then we get to this part. If everyone remembers, we have too much blood, not enough blood, and really not a stroke at all. If you have too much blood, that's easy for me. I'm not a neurosurgeon. There are no neurosurgeons at NorthCrest. I get you to a neurosurgeon ASAP. Because we have that primary stroke center connection, we have a direct line. It's literally a bat phone that sits in the corner. It's a life flight helicopter. Pick it up, how fast can you get here? They get there, they can fly you to Vanderbilt. If Robertson County EMS just happens to be there getting a bag of chips, I can say, "Hey guys, this one's going straight to Vanderbilt." We can get you out of there and to a neurosurgeon within half an hour, round trip via helicopter. If you prefer any other facility, by law, I can send you to any other facility. I can get you to Skyline, St. Thomas, wherever you want to go. I just know I already have a direct automatic admission at Vanderbilt. If you want to go anywhere else, that's fine. And for our paperwork, we put Vanderbilt so no one gets confused, but we'll always double check before we let you go. If you have the ischemic kind, I've hopefully preached this enough, time sensitive. Are you eligible for TPA is where it branches. Can you get that clot buster? Did you get here in 3 to 4 hours of your symptoms starting? If yes, we give you that clot buster within an hour of walking into the door. Now, afterwards, we do talk to you about the next steps, whether you stay at NorthCrest or go somewhere else. If you remember, I said it briefly, clot busters can break up clots anywhere. So if you end up bleeding into the brain, unfortunately, which is a known side effect and a known risk we will go over with you, you want to already be in a place with a neurosurgeon. You don't want to then have to go. So if we ever give anyone TPA, we transfer you right after to the hospital of your choice. Again, Vanderbilt bat phone already ready to go. If you can't get TPA, we do admit you to our hospital. I'll talk about what we do afterwards, but it's a comprehensive 2-day treatment. And if you don't have a stroke, I got to figure out what is going on and get you the appropriate care. So, when you're at NorthCrest, you get admitted because for some reason couldn't get the clot buster too late. We offer post-stroke rehab and follow-up. So we have PT come to work, analyze your disability. Is it arm related? Is it leg related? Is it speech related? We start working on that. You're already admitted for 48 hours the minute we diagnose you with an ischemic stroke. And we have prompt follow-up. We bring Vanderbilt to you. Dr. Gaines, he is the stroke specialist at Vanderbilt. He comes down to NorthCrest about, once a week? Once a week, I think it's Wednesdays. He has his own stroke center there in the little Vanderbilt building over on the side. And anyone who is diagnosed with a stroke at NorthCrest gets automatic follow-up with him. You don't have to drive to Nashville. You just come on down to Springfield. He'll see you in the office, work with you, double check your medications. Are you taking your daily aspirin? How's physical therapy going? Everything along those lines. We've also found in medicine, this is going to come as a shocker, when you're close to family and close to things that you know, you do better. You're not in a foreign environment. You're not worrying about other things. People can visit you more often. You get to be more happy. And a community hospital knows what you need when you're already in the community, right? Do you want to know the local high school game? Someone's probably playing in it right now. Do you want to get the latest update? Usually this is where I make my Smoky Barn News plug. They're my favorite outlet for Robertson County because I need to follow up on what's going on where I work. So that's a resource we already have. If you go down to Nashville and say those words, nobody will really know what's going on. So, in summary, 5 points I'd like you to take home. If you can't remember 5, pick your favorite 3, but hopefully I've made some sort of impact. Strokes are a serious, time-dependent pathology, disease, whatever word you'd like to use. If you think you're having one, if you think your family member is having one, do not waste precious times and precious minutes. Think of your brain like a computer. We were actually talking about this today. Once a computer gets slow, has anyone ever seen a computer magically fix itself? No, it stays slow. Same thing with your brain. It can come up with new pathways, but once it gets there, it's there. And you never notice when it's 1% slower. Unfortunately, we start to notice 30, 40, 50% slower. Slow recognition, again, can lead to permanent disabilities. So if you're watching the game and you think, I'm gonna wait and see this goes away, I understand the minute your pinky twinges, you don't get in your car and come to the emergency department, but don't waste an hour. Don't waste 30 minutes. Get there as soon as you possibly can. The earliest recognition can be made by anyone. You will see stories on stroke survivor websites all across the country. 5-year-old grandchildren notice the first symptoms. They're at church and they can't get up suddenly and someone's a nurse. They just collapse. Anyone at any place at any time can recognize the signs, symptoms of a stroke. Just remember the FAST. Primary stroke centers can offer all the needs in the early phases. You have a primary stroke center just down the street. And finally, lifestyle modifications offer the best prevention. A lot of people ask me, strokes sound terrible. How can I stop it? There's no magic pill you can take every day. However, the better care you're in, the less plaque you build up, the better exercise you get, the more blood flow you can get to the brain. Exercising reminds the brain how to get blood up there. It can make extra pathways. You want to do that as much as possible. Take your daily vitamin. I do not recommend an aspirin a day until you're the appropriate age, but anything to prevent clots is the best way. If you're on AFib, going to get your INR checked, that's important. That Xarelto is important because that one clot can be devastating. No matter how much money you have, no matter how much influence you have, strokes can strike anyone at any time. The best prevention is in your hands.